All right, let's dive in today. We're tackling a topic that, while maybe not a daily encounter for us as ophthalmologists, is absolutely critical to understand, for those moments when it does pop up. We're talking about orbital tumors.
Yeah, those cases where, things get a little tricky and you really have to think outside the box. And, sometimes it can be truly sight-saving, even life-saving, to have that deeper understanding.
And that's exactly what we're aiming for in this deep dive. We've gone through the source material, really dug into it, and we're focusing on two specific types of orbital tumors that, you might encounter in practice,
Mhm.
lymphoma and rhabdomyosarcoma.
Right. It's about being prepared for those less common but potentially high impact scenarios. And I think one of the key things to grasp is, how these two tumor types differ in who they usually affect, and of course, how they might present to us in clinic.
Exactly. So our mission today, in this deep dive, is to give you, as an ophthalmologist, a rock-solid understanding of the key characteristics, how to diagnose them, what to think about in terms of treatment, all based on, the best available information that we have in the source material. So even though, they're not the most common things you see, being aware of these conditions, even the rarer ones, can make a huge difference in how we approach patient care. Ready to jump in?
Absolutely. Let's do it. Let's start with orbital lymphoma.
Sounds good.
So our sources are telling us that orbital lymphomas make up, roughly 8% of all lymphomas that occur outside the lymph nodes. Extranodal is the fancy term,
Extranodal, yeah.
which, when you think about it, the vast number of places lymphoma can show up, that's actually a significant chunk right there in the orbit.
Yeah, it really puts it into perspective, doesn't it?
Absolutely. If you encounter a lymphoma outside the nodes, there's a good chance it could be in the orbit. So I think it really highlights that, for ophthalmologists, we should be considering, orbital signs and symptoms in patients, especially those with a past history of lymphoma. It's a piece of the puzzle we can't ignore.
Absolutely.
And another interesting point is that, the vast majority of these orbital lymphomas fall under the category of non-Hodgkin lymphomas. Now, that's a pretty broad term, right? It encompasses a wide range of different types. But within that, the sources tell us that, roughly 80% actually originate from B cells. And, there's even a figure in our source, figure 4.41a, that beautifully illustrates this. B cells, they're those crucial immune cells, right? Really key players in our immune system.
Right, right. And speaking of key players, isn't there a certain patient profile that we should keep in mind when we're thinking about orbital lymphoma?
You're absolutely right. Typically, we're talking about older individuals. It tends to be a condition more prevalent in that age group.
Right, right. Now, you mentioned earlier this concept of extranodal lymphoma, right? Lymphoma outside the lymph nodes. So when we're looking at a lymphoma in the orbit, how do we figure out if it started there? If it's the primary site or if it's actually spread there from somewhere else in the body, like secondary involvement.
You've hit a really important point there. Clinically, it can be a bit of a puzzle to tease that apart. What's fascinating is, even when it seems like the lymphoma is just in the orbit, initially, what we might think of as a primary presentation, a significant number of these patients will actually go on to develop systemic disease within a few years.
Oh, wow.
So it really emphasizes that we can't just focus on the local problem. It's absolutely crucial to make sure these patients get, a full workup by the right specialists, oncologists, hematologists, to rule out the possibility of lymphoma elsewhere.
That's a crucial reminder for sure. And it sounds like the way this disease progresses, the course it takes, can be, a bit unpredictable.
You're right. It's definitely not a one-size-fits-all situation. And that's what's so interesting about this condition, this variability. In some cases, the microscopic appearance, the histology might really strongly suggest lymphoma. But then, surprisingly, the lesion might just disappear on its own, or maybe it resolves with just steroid treatment.
Interesting.
And on the flip side, you might see something that, initially looks like a benign kind of buildup of immune cells, what we call reactive lymphoid hyperplasia. And then, lo and behold, over time, it transforms into lymphoma.
So it's not always a clear-cut picture from the get-go.
Not always. It's a reminder that, diagnosis can be challenging. And even with the biopsy, sometimes you're still left with some degree of uncertainty.
Right, right. And when it comes to prognosis, the outlook, does the source material tell us anything about, which patients tend to do better or worse?
Yes, definitely. It highlights that generally smaller lesions and those that are just in the conjunctiva, the clear outer layer of the eye, those tend to have the best outcomes.
Okay, that makes sense.
And, it also mentions that, lymphoma specifically affecting the conjunctiva and the inside of the eye, those are discussed in more detail in another chapter, so I won't delve into that too much here.
All right, good to know. So we've talked about what it is, who it affects, a bit about the prognosis. But for us, at the front lines, what should we be looking out for? How do we even begin to suspect orbital lymphoma in our patients? What are the red flags?
Okay, so the sources tell us that the onset is, typically insidious.
Insidious meaning.
It kind of sneaks up on you. It develops gradually and subtly. It's not this dramatic, sudden onset kind of thing.
Okay, I get it. So it can be easily missed in the early stages.
Yeah, exactly. And what's more, many patients might not even have any symptoms at all in those early stages. But, as the lymphoma grows, as it progresses, they might start to experience things like, well, a vague discomfort around the eye, maybe some double vision, or a feeling of pressure or fullness. Sometimes they describe it as their eye bulging or protruding, what we call proptosis. Or, in some cases, they might actually be able to see or feel a mass or swelling around the eye.
So a lot of non-specific things initially.
Yeah.
But when we actually examine these patients, get them in the chair, what are some of the key findings in the orbit itself that might tip us off to lymphoma?
Okay, so first off, it's important to remember that lymphoma can really affect any part of the orbit. And there's a helpful figure in the source, figure 4.41b, that illustrates this nicely.
Okay, yeah.
Now, if the lesion is located more towards the front, what we call an anterior lesion, you might be able to actually feel it during your exam, during palpation. And often it has this, distinctive rubbery consistency. Figure 4.41c actually shows this quite well.
Oh, interesting.
Now, remember, the lymphoma doesn't always have to be right in the main orbital tissue. Sometimes it might be confined to the conjunctiva or the lacrimal glands, those tear-producing glands. So in those cases, you might not see much involvement in the deeper orbital structures.
Right, right. And of course, part of a thorough exam, we're always palpating those local lymph nodes, right?
Absolutely, always. Checking for enlargement or tenderness in those nodes around the head and neck. But, as we talked about earlier, the source really emphasizes the importance of a full systemic evaluation by an oncologist or hematologist to figure out if there's lymphoma elsewhere in the body.
Yeah, essential to get the full picture. So we've talked about the exam findings, but what about investigations? What role does imaging play in diagnosing orbital lymphoma?
Imaging is definitely crucial. Typically, orbital MRI is our go-to in these cases, and figure 4.41d in the source material actually shows a beautiful example of an orbital lymphoma. You can see the tumor, outlining the right optic nerve sheath, and it's extending all the way back to the orbital apex.
Wow, yeah, very clear.
But, while imaging can be very suggestive, point us in the right direction, it doesn't give us the definitive diagnosis. For that, we need a biopsy. That's where we take a small sample of the tissue and look at it under the microscope to actually confirm the presence of lymphoma.
Makes sense. So biopsy is the gold standard.
Absolutely. And once we have that confirmed diagnosis, we need to move on to systemic staging. That's where we do further tests to determine, is the lymphoma just in the orbit or has it spread to other parts of the body? It helps us understand the extent of the disease, which of course is going to guide our treatment approach.
Right. Essential for treatment planning.
Yeah.
So let's talk about treatment. What are the typical options for orbital lymphoma?
Okay, so for those localized lesions, where the lymphoma seems to be contained to the orbit, radiotherapy is often the primary treatment modality.
Okay.
Now, if the disease is more widespread or if it's one of those subtypes that tends to be more aggressive, then chemotherapy is typically used.
Right. To target those cancer cells throughout the body.
Exactly. And, what's really interesting for us as clinicians is the mention of emerging therapies, especially immunotherapy like rituximab, that targets, specific proteins on B cells.
Ah, targeted therapy.
Yes. And the source actually suggests that, in the future, these targeted therapies might play an even bigger role in the treatment of orbital lymphoma, becoming even more dominant.
That's very promising.
It is. And, in certain situations and occasional cases, if the orbital lesion is, very well defined, very accessible, then surgical resection, actually removing the tumor, might also be an option.
Interesting. So lots of tools in the toolbox. All right. Well, I think we've covered a lot of ground with orbital lymphoma. Should we shift gears now and talk about rhabdomyosarcoma?
Yeah, let's do that.
Okay. So rhabdomyosarcoma, I've always had a hard time with that word.
Me too. Most people just call it RMS for short.
RMS. That's easier.
way easier. So RMS is a very different beast altogether. We're told that it's actually the most common type of soft tissue sarcoma. And sarcomas are cancers that arise from connective tissues, like muscle, right, in children.
Hmm.
And, a large percentage of them, something like 40%, actually occur in the head and neck region.
So definitely relevant to us as ophthalmologists.
For sure. And, within ophthalmology specifically, it's considered the most common primary orbital malignancy in kids. But, it's important to remember it's still rare overall.
Okay, good to keep in mind. And thinking back to lymphoma, the age group we're talking about here with RMS is quite different.
It's completely different. With lymphoma, we were talking about older adults. Here, with RMS, we're talking about kids. About 90% of cases occur in children under the age of 16.
Wow, so young.
Yeah. And the average age at diagnosis is around 7 years old.
Okay, so very much a pediatric population.
Exactly. So we need to have that in mind when we're thinking about this condition. Now, the source goes into a bit more detail about the tumor itself. It tells us that it originates from undifferentiated mesenchymal cells. And these are, kind of like those early stage cells that have the potential to develop into various types of connective tissue, including muscle. And these cells in RMS, they have this tendency to differentiate into striated muscle, the kind of muscle that we can control voluntarily.
Okay, that makes sense.
And there are some known genetic predispositions as well, including variations in the RB1 gene. And, you might remember that the RB1 gene is also strongly linked to retinoblastoma, that cancer of the retina.
Ah, yes, right.
Yeah. And then there's this growing body of evidence suggesting that epigenetic dysregulation also plays a role. Basically, changes in gene expression, but not because of alterations in the DNA sequence itself.
It's always fascinating how much complexity there is at the cellular level.
For sure. And then to add another layer to all of this, we have to remember that RMS isn't just one homogeneous thing. The source material actually breaks it down into different subtypes, which is important because these subtypes can have different implications.
Right, different prognosis, different treatment approaches, all that.
Yeah, exactly. So there are 4 main subtypes that are recognized: embryonal, alveolar, botaroid, and pleomorphic.
Okay, a whole family of RMS.
Right. Now, the embryonal subtype, that's the most common one we see in the orbit. It makes up about 85% of cases. And under the microscope, these cells, they might even show some features of striated muscle differentiation. And there's a figure in the source, figure 4.42a, that shows this. Generally, the embryonal type has a good prognosis with treatment.
Okay, that's good to know.
The alveolar subtype, that one makes up most of the remaining RMS cases. Now, with this one, fewer of the cells actually show clear skeletal muscle differentiation. And unfortunately, the prognosis tends to be a bit worse compared to the embryonal type. And, when we look at these tumors under the microscope, they often have these characteristic chromosomal translocations, basically specific changes in the structure of their chromosomes.
Mm-hmm.
And these translocations can be picked up through a biopsy. Now, the other 2 subtypes, botaroid and pleomorphic, those are much less common in the orbit, thankfully.
Good to know. But, before we move on from the subtypes, there was this one point that really jumped out at me when I was reading through the source material. It's kind of a clinical pearl, a little nugget of wisdom.
Okay.
And it's something I think is super important for us to keep in mind, especially when we're seeing young patients.
Okay, what's that?
Well, the source highlights how RMS in a child can actually mimic an orbital infection, specifically orbital cellulitis.
Oh, that's a good point.
Yeah, and I think it's really important to remember, because orbital cellulitis, it's an inflammation of the tissues around the eye.
Yeah.
Often caused by bacteria, right? And we all know how serious that can be. But, RMS can progress very rapidly as well.
Absolutely.
And the last thing we want to do is, mistake a potentially aggressive tumor for just a simple infection. We need to be really careful, especially because, we're often thinking about infections first in kids, right? So if the clinical picture isn't quite fitting for a typical cellulitis, if something feels off, we should definitely have RMS on our radar.
Yeah, we need to have a high index of suspicion in those cases.
For sure. All right, so we've talked about the different types of RMS, but let's get down to the nitty-gritty. How does this actually present? What symptoms might make us think of RMS in the first place?
Okay, so the classic presentation is usually a rapidly progressive unilateral proptosis. Basically, one eye starts to bulge out, and it gets noticeably worse over a short period.
And, like we said, that can sometimes be mistaken for inflammation, right?
Exactly. It can be a real mimicker, and the speed at which it progresses is really a key feature here. It's not something that happens gradually over months or years. We're talking days or weeks.
Okay, so rapid proptosis. definitely a red flag. And what about physical exam findings? When we examine a child with suspected RMS, what are we looking for?
All right, so the source material tells us that the tumor is most commonly found in the supraonasal. That's the upper and inner corner, or in the superior, the upper part of the orbit. There's a figure 4.42b, that shows this. But it's important to remember that it can really arise anywhere within the orbit.
So not always in those classic locations.
Not always, no. Figure 4.42c actually shows one that's located inferiorly in the lower part of the orbit. And, it can even occur in other tissues around the eye, like the conjunctiva and the uvea, the middle layer.
Okay, so location isn't always the most reliable indicator.
Right. Now, you'll often see swelling and redness of the overlying skin, just like with an infection. But one key distinguishing feature, and this is really important, is that the skin is usually not warm to the touch. That's a big difference from a typical bacterial infection.
So no warmth, even though there's redness and swelling.
Yeah, that's a subtle but important clue. And then diplopia, double vision, that's also a very common finding. As the mass grows, it starts to affect the alignment of the eyes. And pain is actually less common in the initial stages compared to, a raging infection.
So to summarize, rapid proptosis, swelling, redness but no warmth, and maybe double vision.
Yeah, that's a pretty good summary of the key exam findings.
And of course, all of this is just raising our suspicion.
Right.
We need to confirm our suspicions with imaging and biopsy. So what kind of imaging modalities are we using for RMS?
Both MRI and CT scans are helpful in evaluating RMS. MRI, typically, will show a poorly defined mass within the orbit. CT scans, they also show a poorly defined mass, but they often highlight the homogeneous density of the tumor, meaning that it looks fairly uniform on the scan. And importantly, CT can show us if there's any bony destruction in the area, which can be a big clue. And, figure 4.42d in the source, it shows a case with pretty significant bony destruction. And what's even more concerning, you can actually see the tumor extending into the intracranial space.
Oh, wow. So pretty powerful imaging.
Yeah. But just like with lymphoma, imaging alone doesn't give us the final word. To definitively diagnose RMS, we need an incisional biopsy. And the biopsy not only tells us, yes, it's RMS, no, it's not RMS, but it also helps us determine the specific histopathological subtype.
Which, like we said, has implications for prognosis.
Exactly. And it allows us to analyze the cytogenetic characteristics of the tumor, look for those chromosome changes. And then, of course, just like with lymphoma, we need to do a thorough systemic investigation, check for metastasis, see if the cancer has spread to other parts of the body.
Right. And the source mentioned that, for RMS, the lungs and the bones are the most common sites of spread, right?
That's right. So those are the areas we're going to be focusing on in our investigations.
Okay. So let's say we have a patient, young child, they have the classic exam findings, we do the imaging, and the biopsy confirms RMS. What happens next? How do we approach treatment?
All right, so the good news is that treatment for RMS is often very standardized. It's usually based on protocols that have been developed by the Intergroup Rhabomyosarcoma Study Group, IRSG for short.
IRSG, okay.
And these protocols are, constantly being refined and updated based on the latest research findings. But in general, treatment usually involves a combination of radiotherapy, chemotherapy, and sometimes surgical debulking.
Okay, a multi-pronged approach.
Yeah. No, radiotherapy, that's where we use high-energy rays to kill cancer cells. Chemotherapy, that involves using drugs that target cancer cells throughout the body. And surgical debulking, that's where we surgically remove as much of the tumor as possible. And, sometimes that's done before other treatments, sometimes after, depending on the individual case.
Right, it really depends on the specific situation.
It does. Now, one thing that the source highlights, and this is important for prognosis, is that the presence of a single oncogenic fusion gene, which is, an abnormal gene that forms when two other genes join together, that's associated with resistance to treatment and, unfortunately, a lower overall survival rate. But the good news is there's ongoing research into new and emerging therapies. The source specifically mentions the drug entinostat and how it's being studied in combination with chemotherapy. And, it seems like it might improve the prognosis in some of those high-risk cases, but it's important to note that it's not yet a standard treatment. It's not clinically approved.
Okay, so still under investigation, but hopeful.
Definitely hopeful. And the other piece of good news is that for those patients whose disease is localized to the orbit, meaning it hasn't spread elsewhere, the prognosis is generally really good with current treatment strategies.
Okay, that's reassuring. So we've talked about lymphoma, we've talked about RMS, a lot of information to absorb, Maybe we should take a moment to summarize the key takeaways for our listeners.
Yeah.
What do you think?
Yeah, I think that's a good idea.
All right. So I'll start. I think the biggest takeaway for me and for all of us as ophthalmologists is that we really need to be thinking about both lymphoma and RMS when we're evaluating a patient with orbital disease, especially, when the presentation isn't totally straightforward.
Right. It's about keeping those less common conditions in mind, especially when things don't quite add up.
And of course, we have to remember that lymphoma is more common in older adults, while RMS primarily affects children. So age is a big clue right off the bat. And then the way they present can also be very different. Lymphoma often has that slow, insidious onset, subtle signs, while RMS tends to progress much more rapidly, and it can sometimes even look like an infection, like we discussed.
Yeah, those are crucial distinctions for us to make.
And we also talked about how important imaging is, usually MRI for lymphoma and both MRI and CT for RMS. But the bottom line is we need that definitive tissue diagnosis with a biopsy to really know what we're dealing with.
Absolutely. A biopsy is essential.
And finally, understanding those basic treatment approaches, radiotherapy, chemotherapy, and emerging immunotherapies for lymphoma.
Mhm.
And remembering that the prognosis for localized RMS is generally good. That's all important information to have when we're talking to patients and their families and when we're working with our colleagues in oncology.
I agree. It's about having a good grasp of the basics so we can provide the best possible care.
Exactly. All right, so as we wrap up this deep dive, I just want to leave everyone with one final thought. As you're seeing patients, examining them, and you come across those with unexplained orbital signs and symptoms, really try to keep these less common entities, lymphoma, RMS, in your differential diagnosis, especially if things aren't crystal clear.
Right. Sometimes it's those less obvious diagnoses that can have the biggest impact on patient care.
For sure. And remember, you're not alone. Collaboration is key. We need to work closely with our colleagues in oncology, pathology, radiology, all those specialists to manage these complex cases. These conditions, they can be really challenging and they can be sight-threatening, even life-threatening. So that teamwork is really essential.
Absolutely.
All right, well, on that note, I think we've covered a lot of ground today. Thanks to everyone for joining us for this deep dive into orbital lymphoma and RMS. It's been a pleasure.
Likewise.
And, as we think about future deep dives, it makes me wonder, what other seemingly rare orbital conditions might warrant a similar focused exploration? There's always more to learn, always more to discover. So until next time, keep those minds sharp and those eyes open.
Great advice.